Hello dear students, today we talk about topic number 20, computed tomography of abdomen, lecturer Shevchenko Alexander, Baltic Federal University, Medical Institute, Kaliningrad 2020. Currently we can imagine abdominal surgery and especially oncology without computed tomography. Now we see through the tissue and provide the best approach to abdominal surgery and cancer staging. CT scans currently occupy a valuable place in the assessment of almost any significant abdominal disease. However, this is not the cheapest diagnostic method, so we should use it wisely. I want to say more than in this particular lecture we didn't touch the theme of subject of oncology because it's a very complicated subject, and I want to show you normal CT scan of the abdomen and pelvis. We try to look on every organ and on slices in general. I want to show you the basic approach to computed tomography. So let's go. What is computed tomography or CT scan? We repeated this by the third time. So computed tomography uses ionizing radiation, X-ray radiation, in conjunction with a computer to create images of both soft and hard tissues. These images look as though the patient was sliced like bread, thus tomography tomo means slice. Though CT uses a higher amount of ionizing X-ray radiation than a diagnostic X-rays, both utilizing X-ray radiation. These advances in technology, levels of CT radiation dose and scan times have reduced. CT exams are generally short, most lasting only as long as breath hold. Contrast agents are also often used, depending on the tissues needing to be seen. Radiographers perform this examination sometimes in conjunction with a radiologist. For instance, when a radiologist performs a CT guided biopsy. We have spatial measurement of the density of different tissues. They are called Hounsfield units. As you see, we have 2000 Hounsfield units, 1000 less than 0 and 1000 more than 0. It's near the 0, it's density of the water, and near than minus 1000 it's density of the air. As we see, lung is positioned between the minus 600 and minus 400. Fat is around minus 50 and soft tissues plus 50 in general. And if we talk about bones, it's from 400 to plus 400 to 1000. But if we want to speak frankly, close to 1000 plus 1000, it's metal details. It's part of the prosthesis on the CT. We have three major views. This is view this is most standard view. It's axial view. As I pictured this person here, how do we look on the every CT on axial view? We look to this CT like this lying human. We look from his feet So it's feed. Here, this is the left of the patient, always left, and this is always the right of the patient. It is standard scheme. This is a sagittal view. Easy to remember from anatomy. Sagitta from Greek or Latin, I don't know. It means arrow. So this view shows us like the arrow go through the human body. And this is coronal view or frontal view, named by the suture on our skull. And we have to talk one very important thing. It's windows. What does it mean, windows? As we see before, we have different Hounsfield units. And if we talk precisely, what does it mean? We have absolute dark color, absolute black color, on the minus 1000 Hounsfield units. And when we talk about plus 1000 units, we have absolute white color. And between them, we have different shades of gray. Many different shades of gray. But our eye can differentiate only nearly 30 shades of gray. Not 2000, only 30. And what we can do? We can choose some window in this Hounsfield units, and all shades of gray will be placed between this window. So we can use the level 50 soft tissue, yeah, and we can push its width to 200 or 300, so it's not very wide, and we can differentiate every structure in our soft tissues. We have here 3 different examples of different windows. It's normal. Window width of this window is 2000. It's lung window, where we can see the lung. You can compare with this film. We didn't see here any vessels, any lung parenchyma. We can see here only large bronchus, large vessels, and some tumors. But we don't see the lung parenchyma. And what does it mean, the third window that I want to show it to you? Look at every details here and try to predict what does it mean. Look precisely. Okay, as you see here, our bones here and here didn't have visual border, and here we see cortex layer of our bone, so we can understand do we have a fracture of the bone or not. This is good looking sternum, and even we see the structure of the vertebral body on this picture. Another very important way of imaging is contrast CT scan. First of all, we must inject our contrast intravenously, then we must wait some time, and then we must push on our CT scan and image our patient. This is again, I try to show you different windows. We have a level. It is the middle of our width here. If we take normal width, it's placed on 0. Our level is 0, and our width is 2000. You see here lungs. We take our level is -60, and our width 160 Hounsfield units. So let's continue with our contrast imaging. We give our patient intravenously contrast. Then from intravenous contrast, it go to the cava venous system. It go to the right atrium, left atrium, to the lungs. From the lungs, it go to the left atrium, and then it go to the left ventricle and to the aorta and to the different veins. And if we want to image our arteries, we must wait from 20 to 40 seconds. If we want to see portal venous phase, we must wait approximately 18 seconds. And we can use delayed imaging for different purposes. I wanna that everyone who watches this lecture look into your textbook of anatomy and try to remember general points in the abdominal cavity anatomy. How placed peritoneum, what is the placement of every organ in abdominal cavity, what placed retroperitoneally, what placed mesoperitoneally, where different organs connects, how it's placed along with another organs. Check this. If you want to make good assessment of your CT scan, you must provide some algorithm. And I take one algorithm from internet and I show it here, but you can use your own algorithm. It doesn't matter in which turn you check every organ. You must remember, you must look at one point, at one organ at a time. Not at all, not at the whole picture, one organ at a time. You can use your own algorithm, but at first it will be better if you take this algorithm and maybe in further you can use your own. First, lung windows. Look at lung bases and look for free interperitoneal air. Second, bone windows. Look for fractures. Third, liver. Fourth, spleen. Fifth, gallbladder. 6. Pancreas. 7. Kidneys, ureters, urinary bladder. 8. Adrenals. 9. Pelvic organs. 10. Mesentery. 11. Vessels. 12. Bowel. Always check the appendix. And 13. Soft tissues. How to read CT? As I say before, we must understand what we are looking for. We must understand that we always looking from the feet of the patient and on every X-ray, not X-ray, on every CT image. On our right we have left side of the patient, and on our left we have right side of the patient. Okay, and here's the feet. Look at one organ at a time. You must remember this as a rule. So, liver. The Coinot classification of liver anatomy divides the liver into 8 functionally independent segments. Each segment has its own vascular inflow, outflow, and biliary drainage. In the center of each segment there is a branch of the portal vein, hepatic artery, and bile duct. The numbering of the segment is in a clockwise manner. As you see from the gross anatomy, we have ligamentum teres or round ligament and falciform ligament, which divides left lobe and right lobe. But this is not the anatomical division by the vessels which go into the our liver. So we have Cantley line, Rex Cantley. It begins from the placement of the gallbladder and going to the placement of the inferior vena cava. This is really the division of the right lobe and left lobe of the liver. This is the names of different segments of the liver. We have second segment, 4A, 8 and 7 segment. Its division between 4A and B, we cannot see where it's placed exactly. We have see here 8 and 5th segment, 7 and 6, and 2nd and 3rd. First, 3rd, 4B, as we go in further, okay. 5th segment and 6th segment. 3, 4B, 5 and 6, and we have lesser and lesser part of our liver here. Only 5th and 6th. So it's normal view of our CT scan. Here on the picture you see the level on which we took this picture. It's basis of the lungs, right and left lungs. We have the part of the spleen, fundus of the stomach, apex of the heart, ribs, liver, esophagus with air in it, aorta, and thoracic vertebra. Xephisternum, it means xiphoid process of the sternum. And of course we see our liver. As I said before, on your right you see the left side of the patient, and on your left you see the right side of the patient. So that is why you see the liver here. Okay. You see the gas here. This is part of the stomach. This is inferior vena cava. This is our spleen. make the pause on these slices and read every part and try to define where do you see every part of these slices, because it's normal, and you must first of all read how it looks like normal, and then you must go to the pathology, look precisely to these pictures, try to define every part, every organ in the abdominal cavity. Gallbladder. Normal gallbladder is up to 10 cm long and 4 cm wide. Its normal wall thickness up to 3 mm. Gallbladder may have septa. So here we see the gallbladder, its fundus, body and neck. And you must look always on the level which they slice we take, on which we slice that we take the slice. Pancreas. The entire length of pancreas is nearly 10 to 15 centimeters. Pancreatic tail is up to 1.6 centimeters thick. Body is up to 1.1 centimeters thick, and the head ranges from 1 to 2 centimeters in thickness. The main pancreatic duct is known as the duct of Versum. The angle between the pancreatic duct and common bile duct are at their joining points is between 5 degrees and 30 degrees. These ducts open into second part of the duodenum through the ampulla of Vater, which has a sphincter called the sphincter of Oddi. On the normal CT scan, you didn't see the pancreatic duct. If you see the pancreatic duct, it must be dilated for some reason. Maybe it's tumor placed here, or maybe it's calcification on along the pancreatic duct. I don't know, but some reason disturbed this pancreatic duct, and you can see it. And you must understand, we didn't have really anatomical division between the part of the our pancreas. You must roll out some slices to see how the pancreas. As we see here, we see only the head of the pancreas. Spleen. The spleen is underneath the left part of the diaphragm, has a smooth convex surface that faces the diaphragm. It is underneath the 9th, 10th and 11th ribs. The other side of the spleen is divided by a ridge into two regions, an anterior gastric portion and a posterior renal portion. The gastric surface is directed forward, upward and toward the middle. It is broad and concave and is in contact with the posterior wall of the stomach. Below this, it is in contact with the tail of the pancreas. The renal surface is directed medialward and downward. It is somewhat flattened, considerably narrower than the gastric surface, and it is in relation with the upper part of the anterior surface of the left kidney and occasionally with the left adrenal gland. The spleen in healthy adult humans is approximately 7 cm to 14 cm in length. As we see, our spleen is here. Always check the level where we take the picture. Next, we go further to the GI tract. We must understand in how the GI tract we see air bubbles which make out the contours of the organs in which air is placed. If we see some air here which didn't make up any organ, you didn't see the wall of the organ, it can sign to us that it is the free air in the abdominal cavity. Here we see transverse colon, small bowel loop, uterus, urinary bladder, and rectum. I want to talk again about this. If you see on this picture, you must read every organ and you must make pause and try to remember this picture, because this is normal. As you see here, rectum is filled with gases. And we go next to the pathology. This is small bowel obstruction. On the CT, it's a Whirlpool sign. We have scale here, and if you know correctly, normal small bowel must be less than 3 centimeters. And we have widely distended small bowel loops. And acute appendicitis. Here we see the appendicitis. Appendicitis connects to the cecum. Cecum is covered by the peritoneum and placed mesoperitoneally. It means from the only 3 sides of this bowel it has peritoneum. It means it very mobile, and appendix can be placed in many parts of abdomen. It can be near our umbilicus, near the liver, in the right inguinal space, and even in the pelvic cavity. So here we see appendix, and on the further deeper division we have fluid collection here. Appendicular abscess. On these pictures we have 3 gears into the cavity of the bowel. We have halo here and fluid around it. This is our bowel looks white because it's contrasted. And here we have the cavity of, collection of abscess. Intussusception. Where do we see the intussusception here? You see intussusception here. You see the rounded structure with different density, and this is bullseye sign. We see that one bowel go into the another bowel, and we see thickening of the wall of this bowel, and we see another bowel into the lumen of bowel. Sigmoid diverticulitis. You must look onto the sigmoid, and here you see the bowel wall with air bubble in it, and you see that it's going out from the bowel wall. It means this is diverticulitis. Liver laceration. CT criteria for the American Association of Surgery for Trauma liver injury grading system for liver trauma is as follows. I try to give to you the emergency medicine situations. I didn't give you any oncology here because it will be too big material for you. I try to show you some emergency situations, because if you have liver laceration or spleen laceration, you must act immediately. You didn't have any time to wait radiologist or anybody. You must read the CT scan by yourself. Okay. Grade 1. Hematoma subcapsular less than 10% surface area. Laceration capsular tear less than 1 cm depth. Grade 2. Hematoma subcapsular 10 to 50% surface area. Hematoma intraparenchymal less than 10 cm in diameter. Laceration capsular tear 1 to 3 cm depth, less than 10 cm length. Grade 3. Hematoma subcapsular more than 50 cm surface area or ruptured with active bleeding. Hematoma intraparenchymal more than 10 cm in diameter. Laceration capsular tear more than 3 cm depth. Grade 4. Hematoma ruptured intraparenchymal with active bleeding. Laceration, parenchymal disruption involving 25 to 75%. Hepatic lobster involves 1 to 3 choanal segments with 1 lobe. Grade 5. Laceration, parenchymal disruption involving more than 75% hepatic lobe, or involves more than 3 choanal segments with 1 lobe. Vascular, juxtahepatic venous injuries, inferior vena cava, major hepatic vein. Grade 6. Vascular hepatic avulsion. And here we see laceration of the liver, here. And here we see laceration with hematoma. Different densities we see here. And another example, we have laceration with hematoma. Here we see different densities in the structure of the liver parenchyma. If we use special application to look on the CT scan, we can choose every part of the CT and we can understand what is the density of this part. And if we took this density, we must look what is the density of the structure. Maybe it's water, maybe it's purulent content, maybe it's fat density. We must look at all of these parts. Hepatic hydatid cyst. It means this is parasite, it's a hemococcus cyst, and we must provide an operation in this case. Acute pancreatitis. It's very common situation here, and what I want to ask you, why we see here on the B we see pancreas, on the C we see pancreas, on the D we see the part of the pancreas, and why we have here this A? We didn't see any pancreas here. We see the lungs, we see the heart, we see the aorta and parts of esophagus. Why? Why it placed here? I show you. Because here on the bottom we have fluid in the pleural cavities. This is one of the signs of the pleural effusion. It's one of the signs of acute pancreatitis. Okay, this is pleural effusion. This is placed between the lungs and between the ribs. And if we look here, we see the difference in the density between the normal parenchyma and between the necrotic part of the pancreas. We have Balthazar score, which is used in CT severity index for grading of acute pancreatitis. It is as follows: normal pancreas, score is 0. Enlargement of pancreas, score 1 point. Inflammatory change in pancreas and peripancreatic fat, score 2 points. Ill-defined single fluid collection, score 3. 2 or more poorly defined fluid collections, score 4. The extent of pancreatic necrosis is graded as follows: score 0, score 2, score 4, and score 6. You must write down this score. And we go further. Another one very important part of our emergency surgery is spleen injury. As you see, we have different densities between spleen and hematoma. Here we see the rupture of the spleen with hematoma. We see the fluid. This is the fluid on the D picture, not like on the A picture. You see another density here and here. This is density of the fluid. Splenic CT injury grading scale. Grade 1, laceration less than 1 cm deep, subscapular hematoma less than 1 cm in diameter. Grade 2, laceration 1 to 3 cm deep, subscapular hematoma 1 to 3 cm diameter. Grade 4, laceration more than 3 cm deep, subscapular hematoma more than 3 cm diameter, parenchymal hematoma more than 5 cm. Grade 4, laceration involving segmental or hilar vessels producing major devascularization, more than 25% of spleen. Grade 5, shattered spleen or avulsed spleen with total devascularization. CO-RADS classification. Why I place it here? This is not abdominal cavity, but I want from you that you learn whole your life. If you want to be a good doctor, you must be up to date whole time. And you know, now we in the middle of COVID-19 pandemic, so I think it is very important to show you CO-RADS classification, because you can meet these anywhere, and I didn't give it to you, and I feel guilty if I didn't give it to you, because I want from everyone to know what does it mean if you see it on the CO-RADS, that you must take immediate action if you see some changes in the lungs. The CO-RADS classification is a standardized reporting system for patients with suspected COVID-19 infection, developed for a moderate to high prevalence setting. This is proposed classification system for radiologists in the Netherlands and still work in progress. This classification was made on 25 of March and still updated. So we have CO-RADS 1, we have normal or non-infection abnormalities, we have no signs of COVID. CO-RADS 2, it's low suspicious level, abnormalities consistent with infection other than COVID-19. CO-RADS 3, intermediate degree, unclear whatever COVID-19 is present. CO-RADS 4, it's a high suspicious for COVID, and CO-RADS 5, it's a typical COVID picture. CO-RADS 6, it's PCR positive result, so we know that this patient have COVID-19. CO-RADS 1, COVID-19 is highly unlikely. The CT is normal, or there are findings that indicate a non-infection disease like congestive heart failure, sarcoid histoplasmosis, malignancy, or fibrotic if unchanged to prior examination. An exception has to be made for the first few days of a mild infection when the CT can be normal. The CT images a patient with complaints for 5 days. There are no abnormalities and the PCR was negative. CO-RADS 2. Level of suspicion of COVID-19 infection is low. Findings consistent with other infection like typical bronchiolitis with free in body and thickened bronchus walls, tuberculosis, no typical signs of COVID-19. The CT image shows bronchiectasis, bronchial wall thickening, and free in body, as you see in arrows. There are no ground glass opacities. CO-RADS 3. COVID-19 unsure or intermediate. CT abnormalities indicating infection but unsure whether COVID-19 is involved, like widespread bronchopneumonia, lobar pneumonia, septic emboli with ground glass opacities. And you have here 4 cases with definitions. CO-RADS 4. In the CO-RADS 4, the level of suspicion is high. Mostly this is suspicious CT finding, but not extremely typical. Unilateral ground glass, multifocal consolidations without any other typical findings. Finding suspicions of COVID-19 is underlying pulmonary disease. CO-RADS 5. Multifocal ground glass opacities and consolidation. Alexander Prokoptsov, tell me that you were asking about what difference between ground glass opacity and consolidation. It's not very high resolution, but I try to explain. If you see consolidation and what's the difference between consolidation and ground glass opacity? Here we didn't see that because it's not very high resolution here, but if you see the spot on the lungs, this is slightly wider than the another part of the lung, and you can see the small blood vessels in the lung through this wider part, like here or here. This means this is ground glass opacity. And if you see slightly wider part of the lung and you didn't divide where is the one parenchyma and where are the vessels, this is consolidation. You cannot assess the vessels of the lung. I hope you understand. And here we see CO-RADS 6. Patient with positive PCR and bilateral ground glass opacities. This is the Hall sign here. Yeah, we didn't have good resolution here. So here you can see the vessels through the part of the ground glass opacities. And consolidation will be whiter, or whiter if you want, than another part of the lung. So what is with COVID-19 typical findings? It's multifocal ground glass opacities, peripheral and basal distribution, unsharp demarcation, vascular thickening, round, crazy paving pattern, ground glass and consolidations, a reversed halo. This is halo sign if we see lighter halo and less denser part in the center of the halo. It's called reversed halo sign. How you can measure the density? I say you before. If you use the application, you can choose every part of the lung and it show you approximately what is the density of this part of the lung. And spiderweb pattern, atypical findings, central or peribronchial vascular, more atypical distribution, lymphadenopathy, very atypical cavitation calcification, free in blood, bronchiolitis, nodular pattern, mass and pleural thickening. Topical findings, most of the cases is bilateral. So we have ground glass opacities in the both lungs, here and here, for example. I want to show you one small film.
This is a short video that is designed to review the CT chest findings in COVID-19. And we're going to get to it right away by showing you cases. And we're going to define basic terms for the beginners as we go. So early on in COVID-19, usually in about the first 4 days or so, you classically are going to see a bilateral process with...
Here we see actually ground glass opacities because you see the difference in the density of lung and our part of atypical pneumonia, but you can see the vessels through this slightly lighter part of the lung.
Ground glass opacities, that's most frequently posterior and peripheral in distribution. The ground glass opacities have often been noted to be rounded in nature. So let's review what we just said. So bilateral in both lungs, ground glass. So this is an example here of a rounded ground glass opacity. So ground glass just means an opacity that does not obscure the underlying vessels. So you can see the vessels through this opacity. This is a ground glass opacity. And as I mentioned, in COVID-19, they've often been observed to be rounded. So if I scroll through this case here, we have bilateral rounded ground glass opacities. As things start to progress around 4 to 8 days or so, you're going to start to see more crazy paving, and that's what we're showing here. And so crazy paving refers to this pattern with septal thickening on top of a background of ground glass opacity. Also notice in this case that there are bilateral infiltrates with crazy paving that's predominantly peripheral and posterior, and there are a number of other locations with more rounded involvement as well. The observation was made by some radiologists that we're often seeing this pattern, or sometimes seeing this pattern called the reverse halo appearance, or the atoll sign, in patients with COVID-19. And that involves opacities or infiltrates with more peripheral high attenuation and lower attenuation centrally. So we see that bilaterally here. And we often see this reverse halo or atoll sign in patients who have organizing pneumonia. And although this isn't pathologically proven, that could suggest that organizing pneumonia is the pathologic response that we're seeing to this infection. And so again, notice in this patient too, there are bilateral ground glass opacities. In this case, we have crazy paving and our reverse halo sign we talked about, and other rounded opacities throughout the lungs as well. As things continue to progress, peaking around 10 to 13 days, you often get full-blown consolidation. And as shown here, consolidation is essentially just an infiltrate where you can't see the vessel through it. So this is an example of an area of consolidation in this particular patient. And so oftentimes we're seeing combinations of these findings. It's not so stepwise as we've been presenting it. So in this patient, we have areas of ground glass change or some crazy paving as well. We have areas of consolidation, as I showed you earlier. And even here we have a little bit of a reverse halo type of appearance here as well. And although we say it's most commonly bilateral, it can be unilateral. So this is a patient who had COVID-19, and you notice that it's predominantly in the right lower lobe here. We have areas of clear, crazy paving here, areas of ground glass change down here as well, and the left lung is relatively spared. So this one happened to be more of a unilateral process, but the vast majority are going to be bilateral. When patients get really sick and get ARDS or acute respiratory distress syndrome clinically, the pathologic correlate in the lung is that of diffuse alveolar damage, or DAD. The hallmark of DAD in pathology is surfactant destruction. So early on in ARDS, pathologically you see non-cardiogenic edema, inflammatory infiltrates, and hyaline membranes. And oftentimes with ARDS on CT early on, we see ground glass opacities, crazy paving, consolidation that's often diffuse and bilateral. And it usually has less of a zonal predilection. And it's important to know that the term diffuse alveolar damage is a pathology term. It doesn't refer to diffuse involvement in both lungs, but oftentimes we do see a more diffuse involvement in both lungs. A study recently published in Radiology classified a bunch of cases of COVID-19 as mild or severe based on clinical parameters like respiratory rate over 30, oxygen saturation under 93%, or a PaO2 over FiO2 ratio less than 300, which you see with acute lung injury. And then they created a CT chest severity score, and the CT chest severity score demonstrated pretty good performance, and it was able to identify patients with severe COVID-19 based on the clinical criteria. And the CT score itself, in my opinion, is a little bit involved, but it involves scoring 20 different areas in the lung as 0, 1, or 2 based on how much of the particular area is involved. But if you take just the overall idea away, that is, in general, as we might expect, the more area of the lung that's involved or opacified, the more likely it is to be severe. And so these images are from this paper that was published on March 30th, 2020 in Radiology. And so the reference is down here by Yang et al. And so you see here, this is a patient who had mild COVID-19 with bilateral rounded ground glass opacities. This patient happened to have severe COVID-19 clinically, and you can see that the ground glass opacities and crazy paving pattern is involving a larger area of the lung. And this patient here had also had a severe course of COVID-19, and you can again see that a large portion of the lung is involved. And other papers exist where they try to create a score based on how much of the lung is involved, but the basic principle is, as we mentioned earlier, the more lung that's involved, the more likely it is to be severe. Okay, so that's it for this brief review of typical COVID-19 imaging findings. During this pandemic, please remember to socially distance, wash your hands, and stay safe. And regardless of the rules where you live, if you have any symptoms or test positive for COVID-19, stay home unless you're seeking emergency medical care. And if you're not sick, stay home too.
Thank you for your attention. I hope you know you know something new from this video. So goodbye, and we talk further about basics of traumatology and sepsis in the further lectures. Goodbye.